Audio Jungle.
Session was sponsored by Hetero Healthcare, and I will be speaking for a few minutes at the end of my presentation about a product which we have recently launched. The presentation over here will focus on three topics: the brain care score and risk and protective factors in dementia, treatment of dementia with monoclonal antibodies, and treatment of dementia using the Rivastigmine Patch, which was recently introduced in India. Now, the brain care score was developed by the Center for Brain Health in Massachusetts General Hospital in the US. The assumptions of the brain care score are that dementia is at least partly preventable through modifiable risk factors. You may be aware that for the last 10 years, there have been many articles which have appeared in the Lancet on preventable, modifiable risk factors for dementia. I will stress this later in the presentation as well, but you need to know that these modifiable risk factors are not cross-sectional, they are longitudinal. It means that if you are exercising now and exercising regularly is a modifiable risk, a protective factor against dementia, you need to continue exercising to experience the benefits of exercise. If you stop exercising, your protective score now is removed by what you have stopped. The brain care score is not the only instrument. It's one instrument of many that are available to predict different kinds of risk. It is a 12-item instrument evaluating three domains: a physical domain, a lifestyle domain, and a social and emotional domain. It is scored from 0 to 21, with higher scores indicating better prognosis or lower risk of dementia. The physical domain comprises blood pressure recording, HbA1c, glycosylated hemoglobin, total cholesterol level, the body mass index. Lifestyle domain includes diet, drinking alcohol, smoking cigarettes, exercising regularly, and sleeping well. The social and emotional domain includes experience of stress and ability to cope with stress, having friends with whom one can talk, and being able to find a meaning in life. Now let's look at each one of these in turn. Before I start, I need to tell you two things. One is that this was derived using something called a modified Delphi process. The Delphi process means I get a group of experts together and I ask each of them, what do you think is a good protective mechanism against dementia? What do you think is a risk factor against dementia? And everybody gives answers, and no matter what they say, including tying shoelaces and brushing your teeth regularly, I write it down. And then afterwards we go item by item and take a more in-depth perspective. The first round was brainstorming, the second round, third round, fourth round are more in-depth discussions until finally we arrive at a consensus where everybody agrees on what should be included and what should be excluded. That is how this was derived. So that's the first point. The second point is there was no mathematics involved in this. In other words, it was just opinion. It was not based on a mathematical or a statistical or a data-driven derivation, DDD, data-driven derivation. It wasn't, right? So basically, it's opinions, including the scoring. It's opinions. But it's been validated afterwards to an extent, and I'll speak about that also. So as I'm presenting these slides, if you know your BP, your glycosylated hemoglobin value, your cholesterol value, you calculate your brain health care score. your BP is less than 120/80, you get the maximum marks, that's 3. If it's 120 to 139 systolic or 80 to 89 diastolic, you get 2. If you're hypertensive, more than 140/90, either one of them, you get 0. If your glycosylated hemoglobin level indicates diabetes, it's 0, pre-diabetes, it's 1, and not even pre-diabetes, you get a score of 2. I hope you're adding up. If your total cholesterol is greater than 190, you get 0. If it's less than 190 or you don't need treatment, it means your LDL is within range of the current guidelines, you get 1. If you have serious disease present, like hypertension, ischemic heart disease, or anything else, no matter what your LDL cholesterol is, you get 1. Your body mass index, if it is less than 18.5, you score 1. If it's 18.5 to 25, you score 2. If it's 25 to 29, you score 1. If it's more than 30, you get 0. So, overweight, obese. If you are within the normal range, you get the highest score. You need to keep in mind that in India, 23 is the cutoff for overweight, and 27 or 28 is the cutoff for obese. Dietary recommendations, there are 5 recommendations, and you need to see how many of these you meet. 4 to 5 servings of fruit and vegetables per day. It's not 4.5, it's 4 to 5 servings of fruit and vegetable per day. 2 servings of lean protein, 3 or more servings of whole grain, less than 1.5 grams of sodium, less than 36 ounces of sugar. So 1 ounce is 28 grams. You've got to do a little bit of multiplication of sugar-sweet beverages. So basically it comes to something like 1 liter, right? But this is per week. 1 liter is 5 glasses, so maximum of maybe 3/4 of a glass per day of sweetened beverages. So 0 means you don't even get 2 of those recommendations. 1 means you have 2 of those recommendations in the previous guide, and you get a score of 2 points if you have 3 or more of these recommendations. Alcohol intake. If you drink 3 drinks per week, not day, you get 0. 1, if you drink 2 or 3 drinks per week, and 2, if you are a teetotaler or you drink a maximum of 1 drink a week. 1 drink is defined as roughly 12 to 15 ml of ethanol, or roughly 30 ml of 75-degree proof liquor. Like whiskey, brandy, rum, and so on are mostly 75-degree proof. So 30 ml of that, as they say, 1 chota peg is 1 drink. Smoking, if you smoke, 0. If you never smoked in your life or you quit smoking at least a year ago, you get 3. I personally wouldn't agree that quitting 1 year ago gives you 3. I wouldn't give 3 marks for that, because smoking has long-term effects on the cardiovascular system, on the arteries, and so on. But quitting smoking, yes, within a year you can make out the difference. Exercise, 0 is not meeting guidelines, 1 is meeting guidelines. Very stingy with the marks. I would have wanted more marks for exercise over here. So, what are the guidelines? If you're doing moderate intensity exercise per week, like brisk walking, and your total for the week is 150 minutes, that's roughly 20 to 25 minutes a day. Not much, but you get a mark for that. Or if you're doing high intensity exercise, like jogging, which actually isn't high intensity, but according to these guidelines it is, and you're doing at least 10 to 15 minutes, 10 to 12 minutes of that per day, you get 1. Sleeping, if you're not getting even 7 hours of sleep in the night, or if you have a sleep disorder which is not being treated, you get a 0. Or if you have a treated sleep disorder and you're getting 7 hours of sleep per night, no sleep disorder, 7 hours of sleep per night or more, you get 1. Stress level and functioning, high stress with frequent impairment, 0, moderate stress with occasional impairment 1. If you have stress, whatever the level of the stress, if it is manageable, and impairment due to stress is rare, you get 2 marks. Here, this coping is my interpretation. They have not expressively stated it as coping. So by manageable, moderate or high, it means your coping is good, moderate or poor. Social relationships, they have not specifically specified loneliness, which has been associated with an increased risk of dementia. But if a person has few or no friends other than spouse or children, the score of 0. 1 mark if there are at least 2 people other than spouse or children with whom the individual can talk or be personal with, share the problems like private matters, who can be called upon to help. That gets a score of 1. And the last item is meaningfulness in life. 0, no meaning, no purpose in life, struggle to find a reason for existing. 1, feeling that life has a meaningful purpose. So, if any of you have been adding up, how many of you have scored 12 or above?
12.
So, most of you have scored, well, half of you have scored 12 and above. So, if your average age is 57, and I think many of you are too young to be 57, and your median and your BCS score, brain care score, is 12, after 12 and a half years, you have only a 1.3% chance of developing dementia. This is if you are 57 years old. So basically, this was a validation study done by the team from Massachusetts General Hospital, published in Frontiers of Neurology to 2023. In this study, subjects were drawn from the UK Biobank, so not India, which means you cannot extrapolate these findings to India. And there were nearly 4 lakh subjects. Average age 57 years, half of the sample was female. The median brain care score was 12. They were followed up for a median of 12 and a half years. Just over 1% developed dementia. If you have a higher score, it means your risk is less. Overall, a 5-point higher score was associated with a 14% lower risk of dementia. The advantage was greater in younger age groups, which means if you have a high brain care score at a younger age, it means, and obviously if you maintain this score for a long time, your benefits are greater than if you were an older person. And here there's a bonus. These benefits were evident not only for lower risk of dementia, but also for lower risk of stroke. This brain care score is actually full of holes. As I told you, it was derived from a Delphi process. It was not data-driven derivation. It's applicable to US citizens, to UK citizens. It's not applicable to Indian citizens. There are a lot of changes to be made. For example, in the cutoff for BMI, body mass index, they have looked at friends rather than at loneliness. You can have friends with whom you can talk about private matters, but you can still be leading a very lonely life because you don't interact very much with the friends. So there are a lot of holes in that. Yet, I drew this to your attention because this is something that you can actually, the printout which you have over here, this is something that you can actually share with your patients so that they can have a number to put for where they are, and they can have items to motivate them to, for example, start exercising or look after their diabetic control better, or maybe to stop smoking. You get 3 if you're a current smoker, to drink less, and so on, right? So use this for your patients as a valuable tool to motivate them, and perhaps motivate you also in case you need motivation. There are other protective risk factors for dementia. For example, everybody knows that higher education is associated with lower risk. This is very well established. It's been known for more than 30 or 40 years. The poorer the education, the poorer the neuroplasticity in the brain at an early age, the greater the risk for dementia in later life. So all of you would have completed your post-graduation in psychiatry. You would be among the most educated people in the country. So by virtue of being in the audience today, your risk is lower than that in the general population. Intellectual activity, keeping intellectually occupied, like being in CMEs, or doing crossword puzzles, Sudoku, Jumble, Wordle, Kakuro, and all these other puzzles that come in the newspaper. Keeping yourself intellectually active by reading journals, keeping yourself intellectually active by, for example, discussing, debating. Whatever you do that keeps the brain ticking, use it or lose it. So that is a protective factor against dementia. Loneliness is a risk factor for dementia because people who are lonely are likely to have lower stimulation, and if you have lower stimulation, this use it or lose it becomes more not use it and more likely to lose it. There are other factors also which operate when people are lonely. For example, they have less social support, they have more stress levels. More stress means higher cortisol, and higher cortisol means greater stimulation of steroid receptors in the hippocampus, and overstimulation of steroid receptors in the hippocampus is associated with decreased neurogenesis, decreased dendritic arborization, and you know the hippocampus is the seat of learning and memory in the brain, etc., etc. So loneliness acts through multiple mechanisms to increase the risk of dementia. Impaired hearing, impaired vision is also not part of the brain care score. People who have poor vision, poor hearing, which is not corrected, they are less able to figure out what's happening in the environment around them. They are more likely to get inside their own heads and stay inside their own heads. So there is less stimulation, and we know that if there is less stimulation, there is less neuroplasticity in the hippocampus, less neurogenesis, less dendritic arborization, less synaptogenesis, less formation of new glial cells, new endothelial cells, and hence greater risk of dementia. Individuals with higher anxiety, higher depression are at increased risk of dementia. Again, one of the mechanisms, for example, could be hypercortisolemia and compromised neuroplasticity in the brain. Exposure to some drugs has been associated with increased risk of dementia, but the jury is still out on the mechanisms. If indeed these are truly causally associated. Benzodiazepine use, proton pump inhibitor use, and use of other medications also has been associated with an increased risk of dementia, though we don't know whether this is a cause effect or reverse causation. For example, people who are older, who are likely to develop dementia, they are along the road to develop dementia, they're sleeping poorly, they are anxious, they're more likely to receive a benzodiazepine, and when they develop dementia, we blame the benzodiazepine rather than realize the benzodiazepine was a treatment for something that was an ongoing process. So this is yet to be resolved, but these are nonetheless suggested as risk factors for dementia. So we should be careful about the unnecessary use of certain medications in the elderly. Keep in mind that these are risk protective factors, but there are no guarantees either way. It means you could be doing all of these things, get 21 out of 21 and still develop dementia, or you can be not doing all the things and have a score of 0 and still not develop dementia. So there is a lot of overlap in the risk factors and in the benefits and risks. Keep in mind, as I said, there are ceiling and floor effects. What that means is basically there is no guarantee that if you don't smoke, you won't develop dementia. And there's a floor effect that means there's no guarantee if you smoke, you will develop dementia. There's overlap in the variance explained. The 12 items may not be independent risk factors, like smoking and drinking may go together, like diabetes and cardiovascular disease in including hypertension, they go together. And when that happens, there could be overlap in the variants explained, which is why I told you not being a data-driven derivation is potentially problematic. Keep in mind that there could be a bidirectional relationship with risk. People who are at increased risk of developing dementia could become lonely, and people who are lonely have less social stimulation, so they are at increased risk of developing dementia. So each one is responsible for causing and maintaining the other. Finally, I remind you that protective and risk factors need to be viewed longitudinally. They are not something that need to be present at one point in time to protect you into the future. If you are not smoking, you must keep on not smoking if you want to be protected against dementia. So moving now to monoclonal antibodies for the treatment of Alzheimer's disease. These have been introduced in the last 3 or 4 years in the United States. There have been 3 monoclonal antibodies that have been introduced. The first one was Aducanumab, the second was Lecanemab, and the third Donanemab. Aducanumab was approved in 2021. All of them were controversial at the time of introduction. This was one of the most controversial because, firstly, the efficacy itself was controversial. There were two pivotal studies that were conducted as required by the US FDA. It was given accelerated approval. One study found efficacy, one study did not find efficacy. The study that found efficacy found that it was a very small degree of efficacy. But anyway, it was approved because, after all, if it works, you have to approve it as per rules. It was approved in 2021, administered intravenously once in 4 weeks. The target is amyloid beta plaque. There's an antibody-antigen reaction. Amyloid beta is bound and then it is cleared by microglial cells. The problem is, when you have an antibody-antigen reaction occurring in the brain, there is some amount of inflammation resulting. And inflammation can be pathological in the tissue in which it occurs, and if it occurs in the brain, you can have brain edema and brain hemorrhages. And this can actually present with a crisis. This can present with worsening of dementia. This can also be associated with mortality. And Aducanumab was associated with hypersensitivity reactions, and Biogen, which was marketing it, plans to discontinue it this year if they haven't already discontinued it. They are not saying they are discontinuing it because of inefficacy or because of adverse effects. They are saying they are discontinuing it because their focus has shifted. Where has their focus shifted? The focus has shifted to Lecanemab. They have tied up with another company and they are now marketing Lecanemab. Approved last year, it's given as an infusion every fortnight. Again, the target is to reduce amyloid plaque formation. In one study, it showed a decline in cognition by 27% across 8 months. Looks very impressive, but actually this is relative to placebo, and what is a big number in terms of percentage is actually a very small and possibly even indetectable difference in terms of real-life patients. Look at the numbers for infusion reaction. So it is just like other monoclonal antibodies, like for example Rituximab, which is given for so many different indications ranging from liver disease to multiple sclerosis, is also associated with the infusion reactions. So infusion reaction in a quarter of patients, cerebral microhemorrhages in 17%, brain edema in 13%. It's not something that you want the patients to have. Donanemab for early Alzheimer's disease, approved in 2024, that's this year, administered intravenously once in 4 weeks. Again, target is reduction in amyloid plaque. At 1 year, 47% versus 29% of Donanemab versus placebo patients showed stability, cognitive stability, no further cognitive decline starting from baseline. As with the others, it can cause an infusion reaction. As with the others, it can cause the ARIAs. I should have told you those are ARIAs. These are basically amyloid-related imaging abnormalities, cerebral edema, cerebral microhemorrhage, they are ARIAs. So basically the bottom line is that the impressive performances with these monoclonal antibodies is actually more inflated because they are presented as percentages in terms of absolute difference with placebo on the scales on which the outcomes were measured. The difference is very small and perhaps not really detectable in everyday life. Infusion reactions and the amyloid-related imaging abnormalities are a serious limitation, and the cost is astronomical, ranging from a low of about $28,000 a year, that's a low, to nearly $60,000 a year, that's a high. Also unaffordable to anybody who's paying from the pocket, affordable only through insurance, and not all insurance companies in the US or healthcare providers in the US are actually paying for these. So I don't think there's any future in monoclonal antibodies for the management of Alzheimer's disease. So mild cognitive impairment, nothing. We absolutely have nothing that has been proven to work consistently in mild cognitive impairment. You get a few studies here and there which show that donepezil has been effective and that some herbal formulation has been effective, that ashwagandha has been effective and so on. But nothing has been consistently found to improve mild cognitive impairment in any meaningful way. No study worth its salt has found any benefits from mild cognitive impairment. So now we come to acetylcholinesterase inhibitors. There's a long history of use of acetylcholinesterase inhibitors to treat Alzheimer's disease. And what is the rationale for it? Acetylcholinesterase, see, if you think of anticholinergic drugs like scopolamine, they have been found to interfere with learning and memory in rats. So people did studies and they found that acetylcholine was an important neurotransmitter in the hippocampus and it was associated with improved learning and memory. They started experiencing with cholinergic treatments, metclophenate, which was used, I think, for schistosomiasis, right? Any of the younger generation over here, more fresh with tropical diseases, can correct me if I'm wrong. Metclophenate, which has a half-life of 50 days, right? Irreversible inhibitor of cholinesterase, basically like an organophosphorus compound. So metclophenate was an early treatment, but tatrine, tetrahydroaminoacridine, was the first to be approved somewhere around 1993, I think. Yes, and it was withdrawn very quickly because it produced hepatotoxicity. Then came donepezil in 96, rivastigmine in 97, galantamine in 2001. Donepezil has been the most promoted. Everybody, all the companies, and most of the studies, they're all donepezil. Initially 5 mg, then 10 mg, then 20 mg, then 23 mg, basically extending the patent protection. Rivastigmine, surprisingly, has not received the credit it deserves. Firstly, rivastigmine acts on brain-selective ACHE rather than on ACHE, acetylcholinesterase, all over the body. And it also acts on butyrylcholinesterase, which is present peripherally, but it's also present in the brain. So it has a dual mechanism of action. Galantamine also, surprisingly, has not been well promoted. Galantamine also has a dual mechanism of action. Not only does it act on acetylcholinesterase, but it also acts on alpha-7 nicotinic receptors which are involved in cognition, and galantamine increases the presynaptic release of acetylcholine as well. So rivastigmine and galantamine don't seem to have been given enough of credit or promotion in the management of dementia. Now there have been a lot of studies. I'm not going to review all the studies, there is no time. Basically, here is an example of one study with a head-to-head comparison between rivastigmine and donepezil. I'm presenting only this one study because it was a long study. It was a 2-year randomized controlled trial and it was a big study, nearly 1,000 patients. In this study, rivastigmine was administered orally in dose of 3 to 12 milligrams per day compared to donepezil 5 to 10 milligrams per day. About 500 patients in each of the two groups. At the end of 2 years, nearly 60% of the sample completed the study. Adverse effects were more with rivastigmine because it has a dual mechanism of action. But these adverse effects were found only during the dose up-titration phase, not during the maintenance phase of treatment. Rivastigmine was as good as donepezil for cognition and behavior, for measures of cognition and behavior. Rivastigmine was superior to donepezil for activities of global living and for global functioning in the intent to treat analysis with last observation carried forward. Rivastigmine was superior to donepezil in patients who were older, like greater than 75 years, those who had associated Lewy body disease. Wonder if you know, rivastigmine is being approved not only for dementia associated with Alzheimer's disease, but for dementia associated with Parkinson's disease as well. And this study found that it was effective against dementia associated with Lewy body disease as well. And rivastigmine was superior to donepezil in patients with fully expressed butyrylcholine esterase, which means they had a lot of butyrylcholine esterase in the brain. Roughly 2/3 of the sample were fully expressed for butyrylcholine esterase, which means that rivastigmine could be potentially superior to donepezil in 2/3 of the patients who we treat for Alzheimer's disease. What are the adverse effects of choline esterase inhibitors? The most common adverse effects are the gastrointestinal adverse effects, anorexia with weight loss, nausea, vomiting, diarrhea. ANVD is what we used to routinely write as adverse effects of any drug in pharmacology in an examination if we didn't know. Anorexia, nausea, vomiting, diarrhea, ANVD. Cholinesterase inhibitors also cause gastric acidity because cholinergic drugs increase the secretion of gastric acidity. Because of the acidity and the diarrhea getting the abdominal cramps, then through a central action they can cause insomnia and nightmares. Through a peripheral action, just like succinylcholine is associated with fibrillations and fasciculations and hence increased muscle pain associated with ECT, cholinesterase inhibitors, because of increased cholinergic activity, can be associated with muscle cramps and fatigue. Then, because there is more acetylcholine, after the cholinesterase inhibitors, because there is more acetylcholine, there is a vagal effect on the heart, and there can be hypotension with falls and fractures. We need to be aware these are common adverse effects of cholinesterase inhibitors. And I'm drawing your attention to this because using a transdermal delivery system bypasses the gastrointestinal tract. If you deliver the cholinesterase inhibitor through the skin, there is no anorexia, nausea, vomiting, diarrhea, acidity, abdominal cramps, and other symptoms related to GI distress. So that brings us to rivastigmine, which I told you is approved for mild to moderate Alzheimer's disease as well as mild to moderate Parkinson's disease dementia. There have been some studies which suggest a benefit for subcortical dementia, subcortical vascular dementia as well. The patch, which I told you has recently been introduced in India. The dosing bypasses the gastrointestinal tract, so there are minimal gastrointestinal adverse effects. The anorexia, nausea, vomiting, diarrhea, acidity, abdominal cramps, and so on. It was approved in US from Novartis Exelon in 2007. The dosing of the patch is 4.6 milligrams per day for the first 4 weeks, then double 9.5 milligrams per day for the next 4 weeks, and after that 13.3 milligrams per day subsequently. And usually doses do not exceed the 13.3 milligrams per day dosing. The up-titration is not based on 4 weeks, and so on. It's based on need and tolerance. So if the patient is not doing well enough with the lower dosing, the patient moves on to the next one. Oh, by the way, we don't go above this. So it's not 10 to 4 weeks, it is maintenance treatment. And the patient should tolerate it. If they don't tolerate the higher dose, we go to the lower dose. What are some precautions when you dose with the rivastigmine patch? The rivastigmine patch looks like one of those little band-aids. You have seen those band-aids, the little square ones, not the long ones. I'm talking about the small square band-aids where on one side you have a little brown, it looks brown, and on the other side you have those white flaps. You peel one flap, you apply it to the skin, then you peel the other flap and you press it. So the rivastigmine patch looks exactly like that. It's brown on one side, but it's thinner than a band-aid. And on the other side, it's got those two flaps which you peel off, and then the adhesive part you apply it to the skin, and then you pull out the other flap and you press it down. Make sure that you don't touch the adhesive part, because then you'll get some of the rivastigmine yourself, which you don't want. You want the patient to get the rivastigmine, you don't want the rivastigmine yourself. So, the patch should be applied on intact skin. You don't want to apply it on an area with broken skin, or there's a boil over there. There should be no dermatological problem where you are applying the rivastigmine patch. So, if there is a dermatological problem, there's a possibility that the rivastigmine goes directly in the bloodstream, and you don't want that to happen. So, apply it over intact skin, and there should not be hair over there. Like you put it over here on the scalp and there's hair underneath, naturally nothing's going to get absorbed from there. So, hairless skin, you can cut the hair if there is hair, but don't shave the hair, because if you shave the hair, then the skin becomes a little raw underneath, and that can also become a problem. Plus, when they're shaving, there can be microscopic cuts which you may not be able to see, which can allow the acetylcholine to get the rivastigmine to get directly into the bloodstream. Ideally, it can be put over the back. Most people do not have too much of hair over the back. Second and more important, patients with Alzheimer's disease tend to pluck off things. They are fidgety, and if it's put on the thigh, as an example, like for example the nicotine patch, they may pluck it off. So you don't want that to happen. So once the patch is applied, press and hold for a few seconds, maybe 10-20 seconds until you're sure that it is firm. And the next day, each patch is for 1 day. The next day, you can just pull it off, but if you pull it off, it may pain a little bit. So moisten it with some water, wet it a little bit, and then you peel it off. The sites can be rotated in a 14-day cycle. 1, 2, 3, 4, 5, 6, 7, right up to 14. And then once you finish in 14, you come back 1, 2, 3, 4, and so on. Some patients have local reactions, like they can have local itch or local swelling or local erythema. If they have a reaction which persists for more than which is causing discomfort to a patient and which persists for more than a day, then you perhaps should consider discontinuing the treatment. And definitely if the patient has a hypersensitivity reaction, very rare, you should not give the patch. So this is my last slide, and it talks about off-label use of cholinesterase inhibitors. Not rivastigmine alone, not rivastigmine patch alone. I'm talking about all the cholinesterase inhibitors, like donepezil, rivastigmine, galantamine, and so on. So they have been used for a number of interventions. Like in a study published in JAMA Neurology last year, cholinesterase inhibitors were found to reduce delusions and hallucinations in Alzheimer's disease. Not all behavioral and psychological symptoms of dementia, specifically delusions and hallucinations. This was an individual participant data meta-analysis. There were roughly 17 randomized controlled trials which were pooled in meta-analysis in this study. And they found specifically that delusions and hallucinations were reduced by cholinesterase inhibitors. Not any specific cholinesterase inhibitors, but all the different cholinesterase inhibitors in general. It has long been known that behavioral and psychological symptoms of dementia, including anxiety, depression, agitation, restlessness, anger, suspiciousness, shouting, and symptoms of this nature, respond to behavioral interventions, but also respond to cholinesterase inhibitors, because when there are cholinesterase inhibitor associated improvements in cognition, then the individual is better able to understand what is happening around, cope better, and hence experience less anxiety, depression, anger, impatience, etc. Then other off-label use of cholinesterase inhibitors, negative symptoms and cognitive symptoms of schizophrenia. This was actually found in a Cochrane review. Cochrane reviews are very conservative. So Singh et al. In a Cochrane review found that cholinesterase inhibitors were associated with reduction in negative symptom burden and improvement in cognitive functioning, at least improvement on cognitive performances of neuropsychological tests in patients with schizophrenia. And a systematic review and meta-analysis published in Acta Psychiatrica Scandinavica 2 years ago found that cholinesterase inhibitors were associated with a lower burden of cognitive adverse effects associated with ECT. Now, before you go jumping into prescribing cholinesterase inhibitors for these indications, for that indication, definitely yes. For these indications, please remember these are off-label, experimental, and particularly in the context of ECT, the benefit is likely to be too small to be detected. There is a possibility of exploring, probably not for cognitive symptoms, but for negative symptoms, but there is a possibility of exploring for negative and cognitive symptoms of schizophrenia. So I think that's my last slide, and I end over here. Thank you very much.
Thank you, everyone. Right. This gets us to our next session. While we're talking about abuse, more often than not,
Audio Jungle.